Good evening. Welcome, everyone. Thank you for joining us for our bi-monthly Adductoplasty webinar series. If you've not joined one of our programs before, a few housekeeping items to share with you. Upon joining, all attendees are automatically placed upon mute, but we really enjoy for these to be interactive. So if at any time you have a question or would like to comment and contribute to the content that is being discussed at the time, please feel free to type that in at the panel to the right of your screen. We will be monitoring these questions and comments and addressing them throughout, and then we'll have time at the very end for any residual questions or comments that we didn't particularly get to at the time. And on to the main event. Without further ado, I would like to introduce our esteemed faculty and one of our most, if not the most passionate faculty surgeons, KOLs on this particular topic of adductoplasty that we have here at Treace, Dr. Jody McAleer, out of Jefferson City, Missouri. Dr. McAleer, welcome. Thank you for being here this evening.
Hey, Lauren. Thank you for having me very much. How are you tonight?
I'm doing great. Doing great.
Okay. Very good. So like Lauren had mentioned, we're going to talk about adductoplasty. We're going to take a little bit of a different spin. We're going to talk about the adductoplasty technique as it relates to Lapiplasty, but we're also kind of looking to some of the other indications that are available using this particular system for midfoot deformity correction. So I am a consultant for Treace Medical Concepts. So some of the opinions that I have here are mine alone and not necessarily those of the company. But I'd just like to give you a little bit of background on my involvement with Treace, because I'm sure a lot of you get out there and you meet people that are involved in industry, and you meet docs that are participating in some of the research and development and design of some of the products that you may use from day to day. But my background is one of essentially enthusiasm. So my beginnings working with Treace were very much grassroots. We started just as physicians that were looking to find a better way to perform surgery for our patients as it relates to bunion surgery. So, for the most part, I was pretty unhappy with my outcomes when I would do my distal osteotomies, my mid shafts, my opening base wedges, my TMT fusions. I just felt like I wasn't getting the outcomes that I had been promised by some of my residency directors and some of the surgeons that I had trained with, as I was kind of coming up the ranks prior to becoming an attending myself. And so I, in large part, tried to abandon bunion surgery. We maybe would do 20 or 30 of the bunion cases annually in our practice, and we really would almost chase the patients away because we weren't happy with what these things looked like in the short term, and we really didn't like what our outcomes looked like in a lot of cases in the long term, just because you'd see a lot of reoccurrence issues, and we did everything textbook, we did everything as we were trained to do. And then you get into these situations where patients would come in with Metatarsus adductus, and you would legitimately tell the patients, hey, listen, this is a really, really tough situation for you. There's probably no great way to fix this, and I can't do it where I can promise you a particular outcome. So you really need to be in a lot of pain for it to be worth your time and effort to try to get one of these deformities corrected. But then about 9-10 years ago, I started learning about Treace, and I started learning about specifically Lapiplasty, and just a couple of the instruments just made so much intuitive sense to me. I said, I really want to do this because I think that this would make our bunion corrections better. Between my partner and myself, 1,200 cases later, we have not looked back, and we literally seek out the bunion cases and the adductus cases, and we really try to do these because we're so happy with the outcomes for our patient population. And we can see it, the return to activity, the return to function, the lack of reoccurrence, and the ability to really predict the degree of correction that we're able to provide to those patients following surgery. It just completely changed the way that I look at these procedures. transformed my practice, transformed my thought process, so much so that I even apply some of the principles that I've really kind of gleaned from doing this triplanar correction into other components of surgery that I perform with regularity, you know, everything from foot to ankle and lower leg. So just kind of give you a little bit of background on that, not to be, you know, to belabor those points, but I'd just like you to know kind of why I'm doing what I'm doing and why I believe so much in the system. So today our focus will be metatarsus adductus. It's going to be to talk about adductoplasty, like we stated. This is our algorithm for those of you that have been to some of our seminars nationally. You often see this at the beginning of all the lectures. This is our thought process tree, going from identifying the patient with hallux valgus to try to determine whether or not they have some degree of osteoarthritis present at the first metatarsal phalangeal joint. And you can kind of see you walk down this algorithm looking for presence or absence of metatarsus adductus, and then you have a suite of services that you can provide to the patient depending upon your particular area of interest, while keeping in mind that all of these deformity corrections that you see on this slide are all a three-dimensional correction, whether it be a fusion, whether it be multiple fusion procedures like a double, a quad, a 3-2-1, or even in the case of doing a triplanar distal osteotomy, which is with our system, it's highly instrumented and highly reproducible. So you can see here another cross section of all these procedures, and the real basic tenets of what we do is the philosophy of three-dimensional correction. That is the why behind the way that we fix these patients, right? We want these patients to be corrected in a consistent manner, and we always want to address not just the transverse plane, but we want to make sure we're getting the sagittal and the frontal plane dialed in to reduce the sesamoids and make a congruous first metatarsal phalangeal joint and appropriately erectus first ray. So talking about metatarsus adductus specifically, you know, what is adductus? What does it mean to have adductus? Like we were just saying, adductus is not this transverse plane deformity that you find in isolation, but rather it's this kind of global rotational deformity of the entire midfoot. And it tends to affect, in many cases, not just the first, not just the second, not just the third, but in many cases, the fourth and the fifth tarsal metatarsal joints. But what you can see here is the image on the left-hand side. That is a foot with obvious, moderate, maybe even early severe adductus. You know, we don't see any degenerative arthritic changes noted throughout that midfoot. But if you look at that, it's not that the bones themselves are deformed, but rather there's a deviation of the deformity through the tarsal metatarsal joints. So there's an adaptive change that has occurred probably through early youth and birth, right? These patients are typically born with these problems, so they're congenital in nature. And then you get this lateralization or this fibular deviation of the digits that occurs over time due to altered extensor and flexor tendon pull, which leads to this kind of skew appearance of the forefoot. But then also take a look at this image on the far right. So you have this patient with a Lisfranc injury, chronic midfoot fracture dislocation. This is actually one of my patients that I've treated. And this patient has not an adductus, but an abductus, a homolateral deviation of the foot. So can we tackle not just the adductus deformity, can we also tackle this opposite deformity, especially when there's chronic midfoot arthritis, and that could occur in both of these instances. And how do we fix this also, right? So is it enough to flip the cut guide upside down? Some people have tried it. It's maybe not the thing that I would recommend. It's a little bit more complicated than just flipping the guide around, but it's something to kind of start thinking about as we get towards the tail end of our discussion today. So again, it's more than just a transverse plane deformity. It's a deformity in all three dimensions and has to be treated as such. So it needs a reproducible and more conventional treatment other than just making wedge osteotomies at the bases of the bones or making a crescentic osteotomy at the bases of the bones, because again, it could lead to some elevation or depression of the metatarsals, which can change the metatarsal parabola, and that leads to other sorts of problems. So what's the prevalence of the deformity, right? So metatarsus adductus is going to be present in approximately 1/3 of the asymptomatic bunion patients that are coming in to see us. So these patients are coming in and they may have varying degrees of the deformity present. So just because you have adductus doesn't always mean that the adductus has to be corrected, right? So if we have a very large intermetatarsal angle, and we have this big splay between 1 and 2, and we have a really very mild adductus deformity, you may be able to get away with fixing the first ray in isolation. If the foot is flexible, also that could be another scenario where you can kind of just push or bully those metatarsals over laterally as we correct the first. But you really need a good bookend, if you will, in a good triplane correction and fusion of the first tarsal metatarsal joint to kind of keep those metatarsals from all wanting to snap back towards the midline of the body. So in these cases, we really do recommend TMT fusion over doing some type of distal osteotomy. In many cases, it's hard to make a determination, one, whether or not metatarsus adductus is present, and two, what do the traditional angular measurements even tell us? So I'm sure that all of you are familiar with Serralato's angle, maybe some of you with Engel's angle, some of you with Kilmartin's angle, some of you with obviously the intermetatarsal angle and hallux valgus angle. And it may sound very, very elementary when I kind of shout out all of these angular measurements, but the problem is we may know the measurements, we may know how to do the measurements, but what do the measurements actually tell us, and what is the clinical value to those measurements that we may have? So we often say if a patient comes in with a Serralato's angle of 30, 40, 20, what does it mean? What does it tell me from a surgical algorithm standpoint? Does it tell me whether or not I should fix the adductus, whether there's adductus present? And essentially a lot of the information surrounding adductus and the traditional ways that these are measured, it's purely academic and it's not really well studied. So if you go back to the original papers written by Serrallato back in the 70s out of the California school, they talk about adductus, they grade adductus, but there was no real science or data behind it outside of just measuring something and then calling it something, saying it's mild, moderate, or severe, just based upon what they were typically observing. So we just really don't have a lot of information on when to pull the trigger, essentially. So what we tried to do as a surgeon group is we tried to come up with a more simplistic method of measurement and not just a way to determine whether or not the patient has adductus, but whether or not we have enough room to physically put the first metatarsal back into position in isolation. So what we do is we take an axis line, which we measure off of 2 points off the medial aspect of the medial cuneiform. So one point is drawn at the base of the first tarsal metatarsal joint. The second point is drawn at the base at the distal pole or base of the navicular cuneiform joint. We translate the line to the lateral aspect of the first TMT, and we subtend the line, and we see if it intersects with the second metatarsal or beyond. If it does not intersect, we know that we have full capability to put that first metatarsal back into its anatomic position, aligning the first and second metatarsals and making them parallel to one another. In contrast, you can see in this example here on the far right, we're doing the same practice, we're shifting the same line, and then you can see here in this case, the line actually bisects or even falls a little lateral to the second, a little bit more lateral to the midline of the second metatarsal head. And you can see I will not be able to put my first metatarsal back up against that line. I don't physically have enough space because the anatomy of the second metatarsal is so shifted that I can't get the first ray reduced. And so what I need to do is I need to get my lesser metatarsals out of my way, which will give me effective space to put my first back into place there. And you may say, well, why do you draw a line along the medial side and then shift it laterally? The reason we came up with this method, one, it was based upon Dan Hatch's paper originally talking about an axis line for the cuneiform and measuring that in a reproducible way. So we made a modification of that component of it. But two, we find that the anatomy of the medial cuneiform along its lateral border, where it makes a joint with the intermediate cuneiform, it tends to be very variable. So finding 2 points to effectively draw a line can be kind of challenging in this area because the anatomy deviates so differently amongst patients. So the medial aspect of the cuneiform is fairly consistent, and these are two very easy to read and easy to identify points. And so that's why we do the translation and shift version of this line. So if you're interested in reading this paper, we published it. It was in Foot and Ankle Specialist. It's open access. So the reference is on the bottom. So if you screenshot it, you can kind of look at it. And you can see all the details of the line itself. So Serrato's angle is often known to be very good from an inter and intra-rater reliability. So meaning, can I redraw it on the same patient's radiograph with consistency and get a similar measurement over and over again? And can you and I do that same practice and match our numbers against each other with consistency and effectiveness and efficiency, where we're accurately kind of determining what that number is. So we wanted to match the plumb line up against that, and what we found is we have very similar effective numbers from an efficiency and a reproducibility standpoint, both between providers as well as if a singular provider were to perform that task over and over again. So it's an efficient and effective way. So it is verified as far as performing the technique and its accuracy. So often, we talk about, well, can you do something here in isolation in some of these patients? And, maybe I don't want to do the adductus. Maybe the adductus seems like it's a little foreboding. Maybe I'm not in the midfoot a lot. I don't feel as comfortable making my dissection to the second and third TMT. It's an unfamiliar path. For docs that are doing more trauma surgery, midfoot surgery, Lisfranc injuries, things like that, you're going to feel really, really comfortable and confident making that adjacent incision. So making a dorsal medial, dorsal lateral incisional approach to get to all of these metatarsals. But, sometimes you say, well, I don't know if I really want to do this. I can tell you that if you ignore it or you try to push your first-rate procedure, it doesn't matter if it's the distal osteotomy, the MIS osteotomy, the proximal, the double, the lapidus type procedures from a traditional nature, or even if you use Lapiplasty, you're going to likely have a significant reduction in the effectiveness of your procedure, and you're probably going to have what we call a reoccurrence. It's a nice way of saying that we just didn't fix it right the first time, and the first rate was never put back where it needed to be. So you kind of doomed the patient, unfortunately, to some degree of failure here. So you can see in all these cases, it didn't matter what they chose, these cases were not going to turn out well. And you could say, well, what if, what if I want to give it a try anyway? Well, I'm just gonna see what happens. It's got to be better than what they walked in with. I'm gonna push my osteotomy a little bit. I'll do this, that, tighten up the capsule. Maybe I'll throw an Aiken kicker in there. I'll tie everything up really well, and we'll just kind of see, narrow the foot down a little bit. What ends up happening though is if you look at this paper that was written by Choi and colleagues, the patients had a decreased degree of correction and a higher radiographic reoccurrence rate in the MTA population than in the primary hallux valgus population. And the patients also had a diminished satisfaction score. Their VAS, their AOFAS scores, and their overall long-term patient-reported outcomes were all substandard in comparison to the hallux valgus group alone. So as the adductus gets worse, we know the scores go down and these patients just don't do well. So you're almost better off leaving the patient alone and not doing anything for them if you're not going to address the adductus, because ultimately they're going to have trouble and they're going to be dissatisfied. And sometimes we get situations like this. So docs say, well, what happened to my patient? Well, you can see here, here's their film pre-op on the left, a little bit of adductus, pretty moderate hallux valgus deformity, good splay of the intermetatarsal angle, HVA is increased. So you look at that, and then they get the patient on the table, they go, all right, I'm gonna do this. I can do it in isolation. Look, I got this thing nailed. My IM is closed. My hallux valgus angle, it's better. My sesamoids, they look pretty good. I got good hardware in there. I'm feeling pretty good about me. And then the patient comes in and they're not on a non-weight bearing film. They're not being pictured on a C-arm, as you see in that second panel, but they're really truly weight bearing. And what do you start realizing? Look, I lost correction. Well, did you really lose correction? Is it really a lack of holding power of that hardware? Or what really happened is your foot was in different positions at the time of those x-rays, and you weren't getting an orthogonal view. The beam angle had changed on that x-ray. So we went from a supinated position in the immediate post-op to a more pronated position or neutral position in that 1 month post-op. It's probably not fully weight bearing at that point, but then you can kind of see how things look like they're starting to drift and you're already, quote unquote, starting to lose correction. But really what happened is we took bad x-rays also intraoperatively. So it's really, really important to kind of learn the need to get some degree of reproducibility of those films, keeping the C-arm in a more stationary position and moving the foot in and out of the beam during your surgery in order to allow for rapid x-ray taking, as also to allow for true assessment of your correction as you move through the process. And so identification of the presence of Metatarsus adductus really is only one part of your solution, right? So we have to come up with a reproducible and appropriate response so that we don't end up with these kind of situations that you see here, where everyone is just kind of making up their own way of doing these procedures based upon their best practice and their opinions or their way that they were trained. So this was a paper that we had published early on. This goes back to 2021. This is when we were doing a lot of these via freehand cut. So that's how we started also. So we love Lapiplasty. It was highly instrumented. It was very reproducible. And then we said, well, we wish that we could do this with Adductus, but the cut's got to be so hard. The geometry is so difficult of that midfoot. Due to the keystone nature of the second metatarsal being at the highest peak of the arch. The deformity degree is always variable from patient to patient. How could we ever instrument this? So we started slowly kind of working on this, making either singular independent cuts at each joint, and then slowly we migrated to contiguous cuts at the base of the third and second metatarsals. And we were originally making flat cuts at the cuneiforms, angular cuts at the metatarsals. We'd end up with shortening issues and other things. And we kept working and working. And then finally, we got to a point where we're able to estimate the average angular correction that was required to kind of get these patients back below or right around 15 degrees, which is kind of esoterically considered to be like the mid-level of normal. It's just been essentially assigned. It's not really been scientifically verified, but we use that as a benchmark because that's what's acceptable in the community. And so we were able to actually make instrumentation to facilitate these corrections. So these patients, we often hear, why do we want to do a fusion of healthy joints? Why do we want to go after these patients? Aren't we produce a stiff foot with these 3 fusions to get this thing corrected? But the true reality of this, these patients, they don't really have a lot of options. They have deformity at these joints. We need a reproducible method of correction. And when we do osteotomy approaches, we know that the outcomes are going to be somewhat unpredictable. We can't always determine the weight-bearing parabola and how the metatarsals are going to line up. That's going to lead to issues with high points and low points on the weight-bearing surface of the forefoot. They're going to end up with IPKs, calluses, complaints, pain, jamming of joints, other things like that, and it's going to lead potentially to more surgeries down the line. We want to kind of have this as a one-and-done procedure so the patients can get fixed and then put us in the rearview mirror as they move along and continue along with their lives. So we need to, again, follow principles of correction and not traditions, and we have to get outside of this thought process that an arthrodesis is a negative thing and it's something that is not good for the patient, when actually in many cases it's one of the best things for the patient. So that's what adductoplasty does for us. It marries together the anatomic correction that you get with Lapiplasty, kind of like along those lines of reproducibility, and then correcting these deformities in, again, a similar fashion, working through the anatomic apex of the deformity, working through 3 planes for this correction, and working through that consistency philosophy. And so we have a complete armamentarium of instrumentation that's available to us. Everything from singular cut guides, 0-degree gut guides for patients that have just midfoot arthritis that just don't have any angular correction. They just need a straight fusion. We have that. We also have the cut guides, which are used for the Adductus deformity in both a mini and an open style cut guide platform, and we can facilitate the correction of a small, medium, or large foot. So if you have a very petite patient with, size 5.5 or 6 female foot maybe, or if you have a male foot that's, 13, 14, 15, double E, some very large foot, we have a guide that will also allow for coverage of those bones. And again, as you can see here on the far right, top example, Adductus, mid example, straight midfoot arthritis, bottom example, that case that we showed you earlier at the beginning of the slide, the chronic laterally deviated closed chronic injury, now with a correction of those bone segments and locking down of those joints through that fusion process. So what would we do with a case like this? So we have a 43-year-old active female. She comes in, she has pain, she has discomfort, can't keep up with her friends, family, and relatives. She has this lateral deviation of her lesser digits. She's having difficulty fitting shoes. In many cases, these patients have a severe mismatch between their forefoot and their hind foot. So their forefoot is so wide that if they fit shoes, their heel is slipping out of the back of the shoe. But if they would wear a shoe that would keep that from happening, then the forefoot is so kind of bound down and compressed that they end up with pain, discomfort, redness and irritation of the first metatarsal head, and in some cases the fifth metatarsal head, just due to the projection of those two areas of bone prominence. And just as an aside, we often have patients that come in with these deformities, and one of the things they ask us is, do I have to fix my talar's bunion also? And what I'll tell you is, we often don't do any type of work at the fifth metatarsal head. Whether we're doing a 3-2-1 TMT fusion or if we're doing an isolated first ray deformity correction, unless there's severe bowing of the fifth metatarsal, we often just fix the first ray or the first, second, third rays in isolation, and just the overall reduction in the forefoot width makes it so we can forego doing anything at the fifth metatarsal head. And I got to tell you, I've gotten away from a lot of metatarsal osteotomies because of that, because we're getting such a significant reduction in the forefoot width with these techniques. Often these patients also come in with metatarsal pain, so they have metatarsalgia beneath the second and third metatarsals. And so you say, what are our options? Well, this is a very viable option. So this patient returns to activity, we resolve their pain, they get a spontaneous automatic reduction in some cases of these flexible deformities. You get these toes to reduce. You resolve that mismatch in the forefoot to hindfoot width ratio, and the pain is resolved, and you get a normalization of the metatarsal parabola. So we'll look a little bit at the technique here. So high level view, we have our 4 basic steps. So we're going to plane the joints at the midfoot and release the ligamentous tissue at the 3rd and 4th metatarsal. We're going to do a contiguous angular bone cut through the 2nd and 3rd TMT, and then later that would be followed by a first TMT bone cut if we were doing the 3-2-1. We do a compression or an apposition step to bring the bone surfaces together, and then we're going to do our provisional, then our permanent fixation. So the way we go about this is we want to identify our tissue, we want to identify radiographically our alignment. So we want to have 2 parallel incisions, one along the first ray at the first TMT, one along the 3rd ray at the 3rd TMT. We could take a wire or a pin or a hypodermic needle to kind of identify the bullseye zone where we want to start lining up in and around that 2nd and 3rd tarsal metatarsal joint. We're going to make a full thickness controlled dissection through the skin, extensor retinaculum, splitting the tendons. I usually split the tendon to the 2nd digit medially, and I bring the rest of them laterally. And then we do a clean dissection up off the metatarsals, and we're going to elevate the periosteal tissue. We're going to split the muscle, and we're going to expose all of this tissue, including the joints, so that we can take a look, and we're going to basically open this whole thing up like a book. So we're going to open it up, we're going to retract it, it's going to give us our bone exposure that we need, and then it's going to give us the opportunity to lay down our hardware ultimately, and then close those layers, including the muscle, back over this area. And so you can see that it's going to maintain that vascularity and that viability of that tissue. When we look at the midfoot, as we stated before, the second metatarsal is the keystone. So it's the top most superior portion of the arch. It's also really fixated into the midfoot. It does not have a significant amount of sagittal plane motion. I think on average, most of the studies show that collectively the medial column midfoot joints should have in a non-pathologic foot about 7 degrees of sagittal plane motion. Also, again, speaking to the lack of true motion that is present at these joints. So fusion of these joints really doesn't provide the patient with any significant pathology or loss of motion when you're talking about 7 degrees overall motion loss. I mean, that's the average. That's not really a whole lot. So I have no concern about that, nor have I ever seen long-term looking at these patients any adjacent joint DJD secondary to limitation of motion at the first, second, third TMT fusion. So we're going to plane the apex of the 2-3 TMT interface. There's usually a bit of a stair step there, so we have a planing guide. As you see up on the top right, the planing guide fits down in this area. We basically are going to normalize that joint, take that peak off of the second metatarsal, and then we're going to come in on the lateral aspect of the third TMT, and we're going to break down the ligamentous tissue binding the third and the fourth metatarsals. This is going to allow for us to close the foot back down after we take the bone slices out. We're going to set our cut guide. Our cut guide.
Dr. McAleer.
Oh, please. Yeah.
Sorry, quick question. Can you go back to the last slide on that third, fourth release? I know you hit on the importance of that. What is the importance of not fully releasing that? Because we didn't do that initially early on, or didn't do it as aggressively as we realized we needed to. What did we discover? What did you guys discover in the significance of doing that complete release?
Yeah, so here's the thing too. So just thinking about it, if we get the release done right now, or if you'll find out if the release is not complete after you make your bone cuts. Because what you're talking about, Lauren, is when you're trying to close these joints down, you're going to be bound up, because the removal of the bone volume from the second and third tarsal metatarsal joint, as we're trying to close these metatarsals down and close them in an angular fashion, in a rotational fashion, so that we can get the bone surfaces opposed to get the correction done, because we're correcting through the cut. The third metatarsal is physically going to be tethered to the fourth metatarsal, and you're going to end up with a gap at the third TMT at the arthrodesis site. You're not going to be able to close it down. So if you're struggling during the case, and I use that word struggle very loosely, like if you try to close this thing down, it's just not going, pause and ask yourself, did I get a full release between 3 and 4? And if you didn't, that should be the first thing that pops in your mind. Go back with your tritome, break a little bit more of the tissue down, because there's probably a segment of the ligament that still remains. And then you're going to see, after you get that little bit that you left behind, it's going to close down great. Does it kind of answer it?
Yeah, that's exactly what I was looking for. Thank you, sir.
All right. We aim to please, Lauren. So speaking to that also, when you put your cut guide in, you can see the cut guide, this profile of the cut guide on the top of the screen, the one where it's anatomically placed inside the foot. It has a retractor on one end, and then we put the fulcrum in laterally between the third and fourth metatarsal. So that same place where you just did your release, that's another reason to make sure you get a full release, because that acts as a retractor, that 1 millimeter fulcrum. And it also gives you an anatomic reference, so you know where the end of that bone is, because you're adjacent to it within the joint between 3 and 4. So, and you can see what that looks like radiographically on the bottom right when we take an oblique view down the third TMT, and then we also want to do it down the second TMT, because you can see what you're going to cut. You can make sure that the bone segments you want to cut are within the complete confines of the cut guide, and we're not going to cut the adjacent bone. I'm not going to cut the medial cuneiform. I'm not going to cut the fourth metatarsal. And depending upon the patient's foot size, you can go small, medium, or large. I'll tell you, 95% of the time we're using the medium cut guide. That's been pretty standard for years now. Once in a while, use a small for a smaller patient, large for a very large patient, but that gives you the idea. So we want to get that guide pinned, tacked down in place so it's secure. It's not going to move. It's going to retract the tendons. We're always pretty cautious, though. We want to make sure that nothing slips underneath the guide, so we always put a little retractor in there, hold the tendons back, and then we just get that cut complete. After the cut has been done, we're going to remove the slices. Again, I a lot of times will use the tritome, just kind of scoop them and flip them out. There's a straight osteotome that's a peel, pack, and disposable, which works very well for this. There's also one that has a hook on it. It's called lapitome and razor tome. So those instruments are also very good to get these pieces out. But after they're out, this is what we're talking about. This is the magic, right? So this is called the up and out technique. So you can see it radiographically, you can see it clinically. What we're essentially doing is we're pausing this, we're reducing it, and we're closing it. And if you don't have that reduced all the way, and you don't have that release between 3 and 4, that is not going to reduce, and you're going to get stuck there, okay?
Dr. McAleer, on this step, sorry, do you have a tip on this particular part, the importance of manually doing that? If you don't have an extra set of hands, you know, to do that motion, any tips on how to achieve this motion while placing the compressor at the same time?
Yeah, so a lot of times what I'll do is I will hold, so what I'm demonstrating in the top left is the reduction. I'm making sure I can get this reduced. Then what I'll do is I will take my compressor, which you can see on the bottom 2 images here. So let's pretend that we're just looking at the bottom right. And I'll take that and I'll almost act like I'm holding a retractor, and the legs will act like the retractor. I put them up against the bone with, in this case, it would be my right hand holding the thumb pad of the compressor, which is the more proximal segment of the compressor. I will push it firmly up against the cuneiform, so it's really well placed and it's giving me counter pressure. And then I will take my contralateral hand, my left hand, and I will pinch the forefoot, and I will reduce the deformity with my left hand while putting counter pressure with my right hand, and I'll hold it in that reduced position with the proximal leg on the cuneiform and the distal leg on the lateral aspect of the third metatarsal. And I try not to come in on the top. We don't want to be top dead center on that metatarsal. I kind of want to be like almost coming off to the side, right? Because the third metatarsal has a flat dorsal surface, and then it comes down like almost like a triangular or a trapezoidal shape. So we want to not be on the top flat. We want to be kind of around the corner. So, you know, anyone that's in that anatomy, they understand that when they see that, because we want it really lateral and kind of flowing off to the side there. And with it reduced, then I have my assistant, I have my scrub, I have them drill the proximal and the distal half pin while I'm maintaining control. So, because I don't have that extra hand to do it. So I reduce it like that. And then I leave the compressor with a couple of turns just to snug the surfaces up against each other. It's very loose, that knob, when I'm done with it, because I don't want to crush the bone surfaces and I don't want to cause an elevation of the third metatarsal. Over tightening will cause an elevation, and you can feel it if you feel across the metatarsal parabola. You'll feel that third metatarsal elevated, and you can even see the head of the third metatarsal tenting through the skin, because we demonstrate this a lot of times in the cadaver lab when we're teaching docs that are doing this for the first time. We will show them like, hey, let's really crank that down and see what happens. So this way they can identify it in a cadaver, and then they won't do it in a living patient.
That's great. Thank you. Perfect. Yeah,
great.
That's super helpful. Thank you.
So once we get that that provisional fixation in there in the form of the compressor, and you can see that they're laterally on the third met. In this case, we threw an olive wire, which we've gone away from the olive wires a lot. I mean, people still use them. They are 100% appropriate to use. We've gone in many cases to the smooth wires for adductoplasty as well as lapoplasty. And I think some of that convention is because I've migrated many of my patients over to the speed plates. Not that the speed plate is so far superior to the S1s, S2s, S4As, lesser metatarsal plates. They're all excellent. They're all made out of the same titanium 23 metal. Plates, screws, speed plates, all the same. But the smooth wires work nicer with the speed plates, because the speed plates, you don't have the ability to skip a screw and get the plate kind of cinched down, then pull the wire and then drop the last screw. So that the smooth wires that are with a smaller footprint tends to make it so you can kind of work around them a little bit easier. So that's why I've kind of migrated to those. But both implants are excellent. But you can see here in these examples, we're doing an anatomic quad, so full long anatomic quad, and then we're getting ready to remove the legs of that quad once the implant has been activated, and then you can kind of see what that looks like. So it's the pre-drill, tap that implant in, and then remove the cap, and then you can see what that looks like anatomically on the X-rays.
Dr. McAleer, do you ever plate with just the compressor on without throwing any provisional wire across the second? Do you ever do that? Can you do both joints at the same time with just the compressor?
Just with the compressor at the third? Yeah, I've done it. I've done it. It's I would recommend making sure that joint is cinched down with something. I would say 95% of the time I'm probably throwing a wire across that, because I just don't want it to budge while I'm putting my hardware in, right? So when you're putting your implants in and you're pushing and leaning on the bone, the second metatarsal has degrees of freedom of movement. And if I'm a little heavy-handed and I'm not being extraordinarily cautious, you're going to have some shift or migration, which could lead to lack of correction. And now I've made a bunch of holes in my bone, and I don't have a lot of flexibility in where that implant's going to sit. So once it's in, and if I don't like it, I'm going to sit there, scratch my head, and you're probably going to add a lot of time and effort to trying to fix that problem. Whereas if you just would have kept a smooth wire or a threaded olive across that, it would have kept it locked down, and you'd be with a lot less trouble. So it's better to have a wire across it if possible.
Yeah, perfect. Then second question, kind of a two-part here. What is your preferred method of fixation for the lessers? And if you're using the anatomic quad, is there a preferred orientation? It looks like it, at least in this particular image, I don't know if this is your case or not, but it looks like the orientation maybe have been flipped on the second and the third. Does it matter necessarily here? What are your thoughts on ideal fixation for 2 and 3? So
what I've moved all my patients to now is I've started using the micro quads, and I like the micro quad. The anatomic quads are phenomenal, as are the lesser metatarsal plates. So if you want a plate screw construct, they're great. But I've moved the patients to the micro quads because I find them to be very robust. They're smaller, so they're a little shorter, a little stouter. But if I have any issues with the length of the cuneiform, I'm always going to avoid getting into the navicular cuneiform joint. So I really, really like that. But all of them are fine. Now, as far as orientation goes, I usually face them towards each other. So instead of having them in the same orientation, I usually kind of make them so they look like kind of like an oval or a circle if you're looking at them from an oblique view, where
hugging each other.
Yeah, kind of hugging each other, like where the proximal and distal are kind of facing each other, right? So I like that orientation, and honestly, it's just style points. It doesn't really make any difference from a mechanical standpoint. The orientation can be either way. So if it fits better facing laterally or medially when you're putting the plate on for that particular individual, don't have any concern that they're facing each other, facing away from each other, or kind of going in the same orientation, because the engineering team told us it doesn't really make any difference, that it just makes us feel better when we look at it. So we like uniformity. Well, at least I do. I like my obsessive compulsive disorder kicks in. I want everything to be just right. And I want to get it and like what they see. So, but yeah, but either way, yeah. So often we get asked, Lauren, about 4 and 5, right? Do I have to do anything about 4 and 5? If I have some adductus of 4, Can I use a really big cut guide? And can I get 4 and cut 4 also and fuse 4? We hear this a lot. So the 4th and 5th metatarsal, the 4th and 5th ray, those are the mobile. That is the mobile adapter of the foot. That is the flexible portion of the column, the lateral column. We don't want to fuse 4 and 5. The patients have difficulties if we do that. So typically, 99% of cases, we find that we can just push 4 and 5 out of the way. In the really severe deformity, if you're concerned with, kind of getting the alignment just right, you can really physically manipulate, pull, and push 4 and 5 out of the way just by manipulating those joints and manipulating the forefoot by pinching between 3 and 4 and pushing. And you can even put a couple of percutaneous K-wires temporarily to really kind of get those aligned on the lateral column. And then it makes your medial column correction even easier because you're not pushing 3 up against 4 to shift 4 and 5 over at the same time. So I'll do that sometimes in these really more kind of severe deformities. And I find that works actually quite nicely. So main thing is manipulation, and we don't typically have to cut 4 and 5. Sometimes if 4 and 5 are really kind of stuck in position, or if you find like there's some stenosis of the capsular tissue and the ligamentous tissue, you can do a little bit more of a release around the base of 4, and then that will also help get 4 and 5 to kind of shift over. So once you have all this done, you have the patient all closed up, what do you do with them afterwards? Well, this is how we treat our patients. So from a pain perspective, we use a combination of 0.5% bupivacaine plain, and we mix it typically in a 2-to-1 fashion with liposomal bupivacaine, which is time-released bupivacaine. For those of you that are not familiar, it's branded. So it's more expensive. There is a J code associated with it. I'm not supposed to give you billing advice, but it is a billable code, and you typically can get reimbursement, kind of dollar for dollar reimbursement, if you will. I'm not a coding expert, so don't quote me on it. But like in our center, we'll get dollar for dollar back, so it helps to cover for the cost of the drug. The benefit of the use of that is their studies show for hemorrhoid surgery and bunion surgery, you can get up to 5 days of symptomatic relief of postoperative pain. In my practice, I'm finding that we're getting 72 hours, so about 3 days of relief, where the patients are primarily being managed with NSAIDs. So we're typically giving the patients 800 milligrams of ibuprofen every 6 to 8 hours. And then if they start having pain, we convert them usually over to Tylenol with codeine on top of the NSAIDs. And usually we give the patients a maximum of around like 15 tablets of Tylenol with codeine, and they usually don't get through them. And maybe they take a couple the first few days just out of fear more than anything. Another option is to also start them in some cases if they're intolerant of narcotics. I can't pronounce this word. I can't say it. I'm just going to say the brand name, so I apologize, but it's Jornavex. This Suzatrigger, I can't say it, Lauren. I cannot. You can help me if you want. I need a phonetic spelling. I need some.
I don't know what it is.
I can't say it. But anyway, so I apologize. Very unprofessional. So, but Jornavex is a great drug because it is a peripherally acting sodium channel blocker. You can look it up. It is brand named only, but it is great for orthopedic pain. Post-operatively, you start them off with 2 tabs or 2 capsules, loading dose, and then 1 in the morning, 1 at night. That's it. That's what they take. They take it for 7 days post-procedure, and they do really, really well. It's a little bit more on the expensive side, but they have like discount cards and things like that. So we've been using that for patients that are narcotic intolerant, which is really nice. We put them all in a Jones compression dressing. We put them in a cam boot, and we also give them a surgical shoe. So surgical shoe is intended for trips to the bathroom in the evenings. Cam boot, they can walk around in it 10 to 15 minutes per hour immediately after surgery. That's true for 3-2-1 TMT fusion. That's true for first MTP, doubles, quads, Lapiplasty, loose front correction, all of that. So all of those procedures I just named off, that's what we do with all those patients. They take the boot off when they're at rest. The dressings stay on for 5 days. We take the dressings off at 5 days. They can get the foot wet in the shower at day 5. And we let them wash with soap and water, running water in the shower. and we start them on active and passive physical therapy and range of motion exercises. And then we transition the patients to weight bearing in their shoes at week or by week 6. And some of that will obviously be dependent upon like swelling and comfort and different things like that. But we try to limit them to ADLs, and we tell them, you know, don't overdo it. Limit how much they're up on their feet every hour, and then we get them back to their shoes by week 6. So cam boot for 6 weeks, walking, standing, taking it easy in athletic shoes at week 6, and then full activity by 4 months post. This is an example here. Again, same protocols, but here's patient straight up 0-degree cut guide, DJD, osteoarthritis in the midfoot, just a painful midfoot, just getting that taken care of. And we also have the Lisfranc fracture, dislocation, indication, midfoot fusions, whether it be chronic or whether it be acute. We have a mini guide that I alluded to as well, which can allow for you to make the 4-centimeter incision rather than the larger, you know, 6, 7, 8 centimeter incision. If my kids were here, I would say 6, 7, because they hate that now. They used to like it. Now that nobody wants to hear it anymore. So
you said it, and I was triggered even by the initial initial version of it.
Yeah, I do it every time I'm with them. Anytime publicly in a store or anywhere else, I scream it out in front of them and all their friends, and I get the worst looks, and I'm just super not cool anymore. But that's kind of like what we do. We do use this mini guide, and the mini guide is great because if you look at it and you compare it to the original guide, the mini guide has a larger standoff in the center and a lower profile on the medial and lateral aspects. And so the guide can be enveloped by the soft tissue while you're making a singular cut at 3, and then you release the tissue, let it fall back over the guide after 3 is cut, and then you can make the cuts at 2. And then you kind of go back and forth between the 2 areas. And there's a little wall built into the guide so that you can't sweep across and cut any of the tendons or any of the adjacent tissues. So you can kind of see what that looks like here. And there's also instrumentation to help support you lining yourself up appropriately so you can really get right down to that 3-4 interface so you can make that incision as small as possible, and you can get that procedure done through the smallest incision, which effectively should help the patient because you're getting the same correction and then you're getting less soft tissue disruption, which is really beneficial. So everything we do is, it's not just, you know, we don't just make claims without researching what we're doing. So this goes back to some of our more early data. This is a paper that we published in the Journal of Foot and Ankle Surgery. We actually presented this at the manuscript competition, not this year, but the previous year at ACFAS. So we had 43 patients, retrospective looking study, 81% were female, looking at the correction using this particular technique. And so I just give you some little facts and figures here from the paper. But what we found was our patients, on average, the mean to return to weight bearing in a cam boot in a protected fashion was 11 days. Return to shoes was 55 days, so just shy of the 2-month mark. Full activity without restriction was 110 days, so just beyond 3 months. And we had an overall reduction in the hallux valgus angle in this patient population, reduction of 25 degrees. The intermetatarsal angle, so the way that we calculated this, we did the true intermetatarsal angle calculation because you can't really just measure the IMA between the first and the second metatarsal when there's adductus because it's not a true measurement, so you have to account for the adductus. So we used the true intermetatarsal angle calculation to what the final x-ray showed. We had about a 20-degree reduction in the IMA, the true IMA. Serrato's angle was reduced by, on average, 16 degrees, and we were able to get the patients to about 10 degrees final Serrato's angle. We reduced these feet with a mean of 1.1 centimeter, 4-foot width reduction, and 97% of the patients were plumb line negative at the end. We had a 100% union rate, and 38 of the 43 patients came in pre-operatively with complaints of lesser metatarsalgia, and post-operatively we had 1 patient with some lingering symptoms. So we reduced and resolved metatarsalgia in 37 out of the 38 patients that reported it. And just interestingly, as an anecdote, we had an over 50% reduction in Serrato's angle. So if they came in with a 40, we got them to a 20. If they came in with a 30, we got them down to a 15. So over 50% reduction in 35 of the 43 patients. So over 81% of the patients had greater than 50% reduction in that Serrato's angle. So really, really interesting numbers, just kind of give you some color to the paper itself. And we're also doing a prospective study. I think we have around 80 patients right now enrolled. So these numbers on this slide are old. Dr. Dayton just presented on this, our colleague, he's the lead author on this one at the manuscript competition at ACFAS this past couple of weeks that just went by. And again, we're never done working on these things. So, we came up with an entire system. We said, this is great. This is working great. We've studied it. We have outcomes. Everything looks great. We're doing prospective work and looking at this and really kind of verifying everything we're saying. And so once we get to a point where we're like, this is great, it's working great, we say, well, what else could we do to make it even better? And so that's what we're working on now. And that is in the form of PSI, or patient-specific instrumentation. And so we've done a bunch of these cases now collectively. I think we have about 6 or 7 of these done at our facility. And so we're saving these in many cases for these really severe adductus deformities. And so this is an example of one of the plans that we had. And so you can see the pre-op up on the left. There's the pre-op anatomy to the post-op anatomy. And how do we obtain this information? This is a combination of weight-bearing, 3-view plain film radiographs in the angle and base of gait, combined with a weight-bearing or non-weight-bearing CT scan with 0.75 millimeter slices or less. And so all of this is rendered by the engineering team into a program that allows for 3-dimensional manipulation of the deformity. It allows for predictable reduction, and you can see the green highlighted bone segments, which is showing the reduction. And then from there, we make calculations to determine the degrees and the angles that need to be cut. And then 3-dimensional cut guides are 3D printed specifically to your patient's specific and unique anatomic needs, which reproduce the virtual correction in the real physical space in the operating room. So that's what we're doing. So this is just kind of like a real stock example here, but you can see what the guides look like on the bone in the 3D rendering. You can see what they look like intraoperatively in the center, and then you can see what that matches up reproducibly on our intraoperative plain films. So again, we have many, many more examples of these. The guides themselves are actually quite elegant, and they're getting much more slimline, and they're going to look a lot similar to what you're used to seeing in the Lapiplasty and Adductoplasty trays. These are older examples. We probably should get some new ones in here that from some updated cases that we've been doing because the guides are like really, really nice. They're really sleek. They're very easy to place, and they really do marry up to the anatomy quite well. And then so you can see what the pre-op to post-operative correction is. You can see what that plan looked like up on the right. So you can see the final result versus what the planned final result was. And ultimately, you can kind of marry this up one-to-one, and you can kind of see what you're able to produce there. And again, this is Treace's post-operative protocol. So, they kind of give like this very generic, when on average patients can get back to walking. And a lot of this is based upon this published studies. But honestly, after doing, again, between my partner and myself, doing 1,200 of these cases on average, everything surrounding Lapiplasty, not just specific to Adductoplasty, but we walk these patients in a protected fashion the day of surgery, all of them, in the boot, in the shoe. We'll limit their activity, manage their expectations. We're very hands-on with the patients. We give them very detailed instructions, all in a written format, so that the patients kind of know what they're up against and what to expect. And then we obviously follow up the patients accordingly. So, so that's what I think I got, Lauren. do we have any more questions? I think we're kind of like right on time too, which I'm surprised.
We are perfect. We are perfect on time. With this may be a first for you and I on this content, but we've hit mostly everything. Maybe we'll leave a little bit here in case anybody wants to type in or chime in with anything additional. But while we're waiting for that, one, thank you so much, Dr. McAleer. Again, I know this is probably one of the most passionate things that you are most passionate about with us, and in terms of correction and Metatarsus adductus and what this does for addressing the entire aspect of the deformity. And the PSI aspect is truly the next generation of this. And if I can speak a little bit to that in terms of what it's looking like in the future is, you know, we often say that metatarsus, you might not see it, but it sees you. So when you're putting in your plan with the system, or to a little bit of a less technological aspect of it, we offer a ton of peer-to-peer experiences, whether you want to submit a case for faculty to review. Faculty can help identify that metatarsus, but then we have the technology now with PSI that says, hey, you know, you're thinking about you're wanting to just address the first ray. There's some adductus present. Is there anything you'd like to address with that aspect? And I can't speak highly enough to Dr. McAleer, you and the team on that aspect of it. So a couple questions have come in. Generally in terms of going away from seeing the metaductus, but what, if any, incidents of neuroma post-op that you have experience with?
Yeah, that's interesting. That we get that question sometimes, and you know, we've talked about this at some of the in-person. It seems like this one kind of comes up at some of the seminars, but none of us have seen any incidents of neuroma formation. And if anything, if you think about it, I do see patients in some cases coming in pre-operatively with neuroma-like symptoms because of the overload of the lesser metatarsal parabola. So they get you know, overload of 2 and 3, 3 and 4, because the first ray is not bearing weight completely, and they get this shift. But post-operatively, after we normalize the parabola, in many cases, I don't find that the patients have those complaints of pain anymore. And I think it's primarily stress-induced, and it's the way that the forefoot contacts the floor when they're walking, but we don't have any incidents of development of neuromas, nor do we have any complaints from the patients post-operatively of those type of symptoms. So I don't think we're creating it. If anything, we're making better conditions so the tripod of the foot is restored, and that should reduce that risk.
Excellent. Next one. If allowing to shower at 5 days, are you using absorbable sutures, or are you removing them at the 2 to 3 week period?
Yeah, so I close the majority, you know, 99% of the patients, unless I have any postoperative edema concerns or things like that. If the patient has pre-existing venous stasis disease and or lymphedema that we're kind of dealing with, I close the grand majority of these patients with a subcuticular running monocryl suture, 4O monocryl, and then I glue the skin. So there's really no suture to remove per se, and we let the patient shower. Now, in the past, I may have closed them with nylon or Proline, and we would let them still all the same get the surgical sites wet, even with sutures in. There's good studies on this that show that there's no increased incidence of postoperative infection with immediate showering. So I let them shower at day 5. It's a convenience in my calendar. I typically operate in and around, like, let's say a Thursday. Patients come back into the office that following week, 5 days out. We get their dressings off, and then we return them to take a shower just at a convenience, and it also helps to reduce that bacterial bioburden. It helps with skin scale and other things like that. We want them to exfoliate. So I'm not a firm believer in like reapplying bandages for weeks and weeks and weeks on end. So, you know, we have them keep it covered with a clean sock. We can give them stockinette or something like that if they would prefer. That's fine. Sometimes we, about 3 weeks out, we do compression hose with the patients to help with any postoperative edema they may experience, the 10 to 15 millimeter mercury compression hose. But yeah, getting the surgical site wet, it is not a concern whatsoever.
Fantastic. That so far is it for any other questions. If anything comes in, we can address them. And if you think of anything after the fact, please feel free to respond to the product management team, to reach out to your local representative, or even the medical education team here at Treace if you have any remaining questions or just, commentary outside of this evening. Dr. McAleer, I know you guys do a ton of peer-to-peer interactions on a weekly basis, which I would like to, broadcast that to the audience here as we talked about looking at Metatarsus. Hey, I'm planning on doing this. But even outside of that, if you are looking for some preoperative guidance or even postoperative advice on something, Dr. McAleer, a little bit on that.
Yeah,
you guys do regularly.
Yeah, the peer-to-peer experience is very good. So, it's kind of like one of those things. If you're in a classroom full of people, sometimes you kind of feel bashful to ask a question. But when we do these peer-to-peers, usually we share x-rays, we talk about some clinical findings, and then we collaborate with the surgeon just to kind of give them, best practices and some insight based upon experience. So it's always a very collegial kind of conversation, and it's always to, answer any curiosities the surgeon may have, around the system, the process, or even if they're very, they're very well versed in doing the procedures, stuff comes up and you say, hey, have you ever seen this, or have you ever seen that, or what would you do with this patient with this particular medical problem? How would you tackle that? Would anything change or be different? And so those are very, very helpful conversations. I wanted to add one thing, Lauren, just in general.
Yeah.
So the PSI system cuts out a ton of the intermediary steps that we showed you tonight. So that's just something to think about. So if you have a really kind of moderate to severe adductus deformity, or even some of the more mild ones, you can do those cases with a much greater degree of ease because the cut guides register to the bone anatomy. So the joint planing step, the ligamentous takedown, all of that kind of stuff that you have to work through and do initially when you do your dissection, that goes away. And what you're left with is you're left with basically getting your anatomy exposed, tacking your cut guide in place, and making your cuts and closing them down. That's it. And so we gave an example recently at a conference that we lectured at. If a really severe adductus, like a severe one, takes me 2 hours, a monster adductus, the worst of the worst, we're doing it with PSI in an hour. And I mean, and that's crazy because you can add another case on for the day. I mean, you have flexibility in time and schedule. The once you get kind of, comfortable with the process, we're doing the mild to moderates in like 90 minutes, skin to skin, injections, bandages on, tourniquet dropped. So just think about that. So mild to moderate with the traditional instrumentation, 90 minutes, monster deformity, 1 hour with PSI. That speaks volumes. So just something to think about if you're kind of interested in the process, procedures, and the technique.
Yeah, no, that's outstanding. And to further on that, we have a number of medical education events, surgeon education events, training, hands-on cadaveric labs happening throughout this year. So please, once again, reach out to your local representative, reach out to the Treace medical education team, the product management team here for any questions regarding these upcoming events, regarding your cases, regarding any product questions. We are always here at your disposal to provide any sort of insight. And thank you for being with us this evening. Dr. McAleer, thank you so much, as always, for these. We enjoy hosting these so much, and appreciate appreciate everything you do to make these a very engaging, successful event.
Yeah, well, thank you guys. Thanks for having me. I appreciate you.
Thank you, and have a wonderful evening, everybody, and we'll see you next time.
Bye-bye.
Bye-bye.